welcome to another Top Doctors Online interview where we speak to one of our leading specialists. Today, we're very fortunate to be joined by highly esteemed consultant obstetrician and gynaecologist, Ms Pushpakala Maharajan, to speak about cervical cancer awareness. So welcome, Ms Maharajan. Thank you so much for joining us today. Would you like to introduce yourself and tell us a bit about your background or your areas of expertise?
Thank you for the introduction and thanks for this opportunity. My name is Pushpakala Maharajan. I work at the Bedfordshire Hospital NHS Trust. I work at Luton and Dunstable Hospital, and I specialize in minimal access colposcopy and ambulatory gynecology. So what I see is women with heavy menstrual bleeding, with abnormal smears, with abnormal postmenopausal bleeding. I do one-stop clinic where I do hysteroscopy and diagnose any abnormalities. Also, my special interests are in HRT as well as women's health.
Thank you so much, Ms Maharajan. So, as I mentioned, our topic today is a really important one, cervical cancer awareness. To start off, could you just tell us how common is cervical cancer in the UK and which types of women are most often affected?
Okay, thank you. Thanks for the question. So I'm going to bring some statistics here. So it is encouraging news, but there is a lot of work to do. So in the UK, nearly 3,200 women are diagnosed with cervical cancer annually. And that would mean 9 women every day. This is from statistics from 2018. Also, we know that this constitutes nearly around 2% of new cancers in women, as well as it is considered as the 14th most common cancer in women. Although we know that previously it was on the first 5 to 10, now it's gone down. And something good we are doing that helps in reduction of the incidence of cervical cancer. The commonest prevalence, the incidence is higher in age group between 30 to 34, and 9% of these cancers are seen in women around age 55 and over as well. If we look at the statistics from 1990, the cancer has slowly started declining and we have seen a downward trajectory, nearly 25% reduction in these cancers. It has remained stable in the last 2 decades as well, which is very encouraging. And it is now found that 65% of the cancers are higher in most deprived quintile compared to the least. And 520 cases every year is linked with deprivation. But the good news is there are 34,800 women in UK after 2020 diagnosed and treated. So the whole cervical screening program is for early detection of cancer so that many women can live a healthy life after the diagnosis and treatment.
Okay, so some really encouraging statistics there. So you've talked about cervical cancer screenings. What's your advice for women listening about attending their cervical cancer screening?
So what I would advise is the cervical screening program was introduced in late 80s, and that was mainly to reduce, the ultimatum was to reduce the risk of cervical cancer. Now, several changes has happened in the last 10 years, I have to say. The significant change came in December 2019 in the UK, when we used primary screening as HPV screening. So that's the biggest change that women, so all the smears that we do in the GP surgery goes and the HPV, high-risk HPV test is done. And once the test is negative, the high-risk HPV is not detected, women are discharged back to 3 years or 5 years, wherever they are in the routine recall system. So what do I mean by that? Women are given the opportunity to have screening between 25 to 64 years in the UK. The initial invite for a smear is sent around 24 years and 6 months, and promptly that invite goes to women, and then from there until the age of 49, it is every 3 years if the smear is negative, and after that from 50 to 64 it is every 5 years. This invitation is an automated invitation that comes as post, as emails, as well as text messages. And what we encourage women is, It's a good opportunity to diagnose abnormality at an earlier stage and get treated. Hence, it's so important not to ignore this invite that comes to them. It is so important to see your GP. And if you worry about this, you could always contact your GP for advice, who will be able to tell you what all this test would involve and what it means. Also, reliable information is available on the BSCCP website as what to expect on the day. So there are a lot of information out there which really highlights the essence of having this screening.
Thank you so much, Ms Maharajan. So really important to keep to those appointments. You've mentioned HPV there, which I'm sure people at home would have heard of, the human papillomavirus. Could you explain what is the link between HPV and cervical cancer, and speak a bit about the importance of HPV vaccination?
Okay, thank you. It's a very relevant question here. First, let me break down this question into two parts. The first part is the link between HPV and the cervical cancer. From scientific evidence, what we know is 95% of the cervical cancer is HPV related. HPV is a commonly seen virus, and it is specific to the reproductive tract. It is mostly the women who are sexually active as well as men will be infected at some point in their lives, and they can be repeatedly infected as well. 90% of the infected population will be able to clear this virus or the infection as well. When they clear the virus, they clear the infection related or the abnormality related to the virus as well. The most important thing here is it takes 15 to 20 years for cervical cancer to develop in someone with normal immunity if the virus has developed an abnormality and it's not been treated. And it takes roughly around 5 to 10 years for someone in a similar situation with very immunocompromised state, weakened immunity. And hence it is so important that you can see the trajectory of the virus is it can cause cancer, but it takes so long. So it's important we ask for help at the right time. So you have time to go and get the smear done. If it's an abnormality, be treated, because you have enough time to get that treated. Most of the women we see who come to us and say they had abnormality or they have early diagnosis of cancer knew that there is something abnormal, but they're scared to go to their doctors or ask for medical help. And that's what we need to focus here. If you're worried, it's important to seek advice and help. And that's important here. Now, looking at the virus, there are so many types, subtypes. So it's really confusing. There are 200 subtypes that the virus has, but we classify that as low risk, high risk. The low risk are mainly that causes, form of warts in different areas, and the high risk virus are nearly 12 types. But the most important one are the 16 and 18 that causes cancer.
Thank you so much. So to just mention a little bit about HPV vaccination in young people, how crucial is that? How crucial is that?
Thank you. So that's the second thing. So we launched the HPV, vaccination program in the UK in 2008. And the first initial studies that these things were based on was that cervical cancer was reduced by almost 90% in women in their 20s if they were offered a vaccine around 12 to 13. That's the evidence. Now, this is rolled out for nearly more than a decade. Now it's time to relook our evidence and see how much it has supported and reduced the risk of cancer. We have started seeing women who had the vaccines now coming with some form of abnormality, but it is something that we have to say, we don't see a lot of high-grade abnormality in this group of women who had the vaccine. The most important thing here is there are evidence from Europe, like Scandinavian countries, which has shown promising results as well. Nearly 63 reduction of cancer incidence in this group of girls or women who had been exposed to the vaccine. So all the studies we have is quite promising and is quite reassuring. And hence it's important for women to be taking these vaccinations. And it is not only for girls, it's also for male children. So both boys and girls are offered these vaccines. So the vaccines that we are given are Gardasil, which is the quadrivalent vaccine. Now, the reason we we give it between 11 to 13 is mainly because, so mainly we target 12 to 13. And that's because if you have a vaccine between 12 to 13, the reduction risk is 90%. If you give the vaccine between 14 to 16 age group, then reduction rate is 62%. And if it's given between 16 to 18, it is 34%. So the earlier we give, the better outcome. Now, we have three different vaccines. One is the Gardasil quadrivalent vaccine, which normally contains subtype 16, 18, and also 6 and 11. The 6 and 11 protects against the warts, and the other 16 and 18 against cancer. The next one is a bivalent vaccine, Cervical 6, which contains 16 and 18 and hence protects against cervical cancer. Gardasil 9 has subtypes which includes 31, 33, 45, 52, 58, and they also give cross immunity to the other strands or the group that we have discussed as well.
Really interesting, especially how those statistics change from age to age. Thank you, Ms Maharajan. So from what you've mentioned, seeking advice early if you've got any concerns is really, really important. Could you just detail what are the signs and symptoms women should be looking out for?
So most of the time it is, although it is very rare, it can cause some symptoms. So any warning symptoms, we say this as a red flag symptoms is what you need to look out for. They include irregular bleeding, bleeding after sexual intercourse, excessive vaginal discharge, very offensive discharge, blood-stained discharge, or bleeding in between periods, pain with sexual intercourse or discomfort with sexual intercourse, unexplained pain, mainly in the back as well as in the hip bone. Those are the main symptoms. So any abnormal bleeding, you need to see your GP, and they would refer you on a 2-week wait where you are referred to the hospital to exclude cancer. If you haven't had a smear in the last 3 years, or you have reached 25 and you haven't had a smear, then obviously your GP will do a smear for you. Or if you are in the group of 50 and above and you haven't had a smear within 5-year period, then they will do a smear. However, if you are in the recall system, there is no indication to do a smear. What you need to have is a colposcopic assessment, which is looking with a microscope on your cervix to rule out abnormality. Because many times I see women saying, I had this bleed, but I couldn't have a smear. Because the guidelines is very clear. Smear is a screening test. It is there to pick up abnormality. However, we want to have better tests, refined tests, accurate tests for diagnosis of cancer and other things. And that's where colposcopy comes in.
Thank you, Ms Maharajan. So the message is, any concerning symptoms, contact your GP.
That's right.
First instance.
That's right.
So let's talk now about risk factors associated with cervical cancers. You've talked a little bit about age groups which are most affected. Which are the factors that can make a woman more susceptible to developing cervical cancer?
So thank you for the question. So we have talked about HPV virus and its exposure and how it causes cancer. And we also heard that 95% of the cancers are HPV related. So that's the majority of cancers related to HPV. So our target is to reduce that 95% of occurrence. So that's where HPV comes into play. However, there are other risk factors. So sexual history comes in also the second most common thing. That's especially when women are sexually active at a younger age group and having multiple partners can increase the risk, because we talked about recurrent HPV infection, and that's where this comes in. Smoking is another risk factor. Now, how does smoking affect cervical abnormality? It changes your immunity. It also causes cell damage at the cervical level, which it predisposes to cervical HPV infection, as well as increase your susceptibility to HPV infection. Having weakened immunity like HIV infections or any autoimmune condition or organ transplant or treatment for Crohn's and other medication, which changes your immunity. And last but not the least, there are other things as well, like having, they say, pregnancy at a very early age group, around 20 years, or multiple pregnancy. And again, that's because it relates to exposure of HPV virus, and that's all about the virus. So all these risk factors are HPV still driven, although the smoking becomes an isolated risk factors. And the last thing is, there is a condition called diethylstilbestrol. This was a medication given for women when they thought they could miscarry, to prevent miscarriages between 1938 to 1971. Now it is banned everywhere. Those group of women, the babies who were born around that time due to this exposure, can develop a cancer called clear cell adenocarcinoma of both the vagina and the cervix. The number of women who are in the system are regularly monitored for cervical cancer and vaginal cancer, and they are on increased surveillance. So they are the group of women who are on yearly surveillance, or they are on much increased surveillance dependent on the risk factors.
Thank you, Ms Maharajan. So finally, could you share with us any insights you have into the latest advancements in treatment for cervical cancer?
Thank you. So there are many, researches that's going around for cancer treatment. And I have to say, everything changes as we are going along. And one of the things is with these cancers, cervical cancer is unique in the sense we have a screening program to pick up these cancers. So most of the cancers we see are early stage, meaning a loop excision, simple cone biopsy, or what we call as laser treatment to the cervix, would be adequate enough to clear the cancer when we pick them at an early stage. And that's the whole essence of being part of the screening program. And so we have to say, most of them who presents to us do have early stage cancer, and loop excision itself is enough, and they are on a 5 or 10 yearly follow-up depending on the local cancer agreement follow-up. Then next stage cancers. So we follow something called FIGO classification, which helps us to identify the treatment option as well as the prognosis for these cancer. So the next stage would be, as you go up the ladder, then the cancer tree is treated with hysterectomy, as well as removing the cervix and looking at lymph node involvement and removing those lymph nodes. So that we call that as a radical hysterectomy or radical trachelectomy with lymph node excision, which is the lymph node where it feeds into. And subsequent, further higher up you go, then you have chemotherapy and radiotherapy. Chemotherapy is where drugs are given through a drip to kill the cancer cells, and radiotherapy is where radiation is given, and that is again targeted to the cervix to kill the cancer cell. So these are the most commonly treated options that we have. However, there are new clinical trials that bring new treatments. So there is immunotherapy, targeted therapies as well. So the immunotherapy in 2018, the FDA approved a treatment called pembrolizumab. This is a treatment for metastatic cancer as well as recurrent cervical cancer. So this is how it changes your immunity and kills the current cancer as well as prevents future cancer recurrence. And targeted treatment is where, as you know, cancer increases proliferation. It increases the cell growth. So we are looking at microscopic level how we can target these cancer cells which has increased cellular growth, and that hence we try to target the growth, proliferation, spread of cancer, and looking at targeting with certain treatment, like looking at P53, epidermal growth factor receptors, as well as vascular endothelial growth factor receptors. So these are the targets, these are the areas you target, which helps in proliferation of the vascular cells as well as the cancer cells. You target with targeted therapy. So there is a lot of experimental treatment available, but what is available in the NHS is the first few ones I have said: loop excision, hysterectomy, radical, and then chemoradiation.
Thank you so much, Ms Maharajan, for joining us today to raise awareness of cervical cancer and share key information for women on the signs to look out for and the importance of screening. It's been really interesting to hear your expert insight, so thank you for joining us.
Thank you. Thank you very much for this opportunity.
Thank you. If you are concerned at home about any gynecological symptoms and wish to schedule a consultation with Ms Maharajan, you can do so by visiting her Top Doctors profile. You can find us at www.topdoctors.co.uk. Many thanks again, Ms Maharajan, for joining us today.
Thank you.